My name is Jessica Holsey with the Addiction Policy Forum, and very excited to have our special guest speaker today, Dr. Jim Barry, on the webinar topic, Digging into the BioPsychoSocial, addressing the holistic and multifaceted needs of individuals in treatment and recovery. Very excited to have Dr. Barry here. He is the professor and the chair of the Department of Behavioral Medicine and Psychiatry at West Virginia University. He's also a member of the Scientific Advisory Board for Addiction Policy Forum. So we're so grateful to Dr. Barry for his input and expertise in APF's programs, research initiatives, and projects. Dr. Barry has developed really innovative community-based treatment programs and treatment models at West Virginia University that are really national models. And such an amazing clinician, one of my favorite people. And thank you, Dr. Barry, for joining us. We're so excited, and I'll hand it over to you.
All right, very good. Well, thank you so much, Jess, and really appreciate you, really appreciate the work of the Addiction Policy Forum. It's an incredibly important service that this group is providing. And thank you so much for the opportunity to be able to present today and be able to at least share some of the things that I've been able to learn over the years, providing direct clinical care, but then also some of the research that we've been doing here at West Virginia University's Rockefeller Neuroscience Institute, and the things that I've learned from my patients and the things that I've learned from the trainees over a year, and what's important and what really needs to stick. So this is an attempt to try to encapsulate much of that. So we'll go ahead and dig in here. What I hope to do and accomplish with our time today is really hit on these bullets. So going through the history of the disease model, and which has been the dominant model of our understanding of disease in general, and then specifically how that has played into our understanding of addiction and the value of that. And then move on to the biopsychosocial model and explore that particular model in each of those domains to some degree. Then we're going to go ahead and look at psychological treatments. And one of the things that I recognize in this very, very broad audience, that there's going to be various levels of expertise. And so what I try to do is strike that balance of giving just enough information for those who this could be brand new information for, and adding a little bit more so it would whet the appetite of those who would like to dig in to understanding these psychological and even social treatments as well. But really, it's going to be more of an overview and an introduction, but digging in a little bit deeper with some as well. Speaking about the social elements in treatment of recovery and how important these are, and then finally the importance of spirituality and faith communities in addressing addiction. Hopefully, if I time this correctly, we should have at least a few minutes at the end for some question and answers. So begin thinking about any questions you would like to ask at the end. Very good. So, Doc, can I get a brain transplant? So believe it or not, this is a question that I will get periodically when people come into treatment. And it really is a legitimate question because so many people have come to the understanding that their brain has really been affected, and that the way they have been thinking and behaving has so much to do with the brain. And there's been a lot of information that's now translated to the public about how addiction is a brain disorder or a brain disease. And so some folks come in and just say, hey, doc, can't you just give me a brain transplant? And this is, also it's the brain that's been the focus of a lot of research over the years and a lot of our studies. But what I want to emphasize in this talk is remind people that we as human beings are not just brains on legs. The brain itself is a spectacularly wondrous and glorious organ. All of our experiences and all of our behavior is mediated through this glorious ball of neural tissue, and it's so incredibly important. And like I just mentioned earlier, much attention has been paid to the brain in the medical and scientific community over the last, 30, 40 years in helping us understand the receptors that are involved in addiction, the neural tracks that are involved in addiction, and even how we might be able to manipulate those neural tracks with either medications or neuromodulation, which I'll talk about later in the talk. Yet, if we truly want to be able to help people, then we need to understand that people are whole human beings, are whole persons, and that understanding the brain is necessary as we consider this and is the focus of a lot of the treatment. But I would argue it's not sufficient to just focus on the brain. And that's where the holistic care comes in. And the root word for health is whole. And humans are richly complex creatures. And we cannot just be reduced to one part of our being, like the brain, to be able to summarize who we are in our whole. And much of healthcare, I would argue, should be trying to bring in all of those parts into a working whole so that we're in harmony with those parts and the world around us. So when I write a prescription for a medication for opioid use disorder, for example, it's not just for the brain. I know it's working in specific pathways and specific receptors in the brain, and I know it's going to have physiologic effects with the medications I give, but I always try to keep that within the context that that's just one part of what I'm doing when I'm writing a prescription. I'm recognizing the importance of therapy, for instance, that some pictures there in individual and group therapy, recognizing that people exist in community. And so having various communities that are healthy to be a part of, the importance of work and purpose and meaning, the importance of a good diet and good exercise. So that is truly a whole and holistic healthcare. Dis-ease, on the other hand, is really a state where the various parts have become fragmented or fractured, and therefore there is a state of dis-ease. And this is a picture here of Dr. Benjamin Rush. Dr. Benjamin Rush was one of our founding fathers in the United States. And he was really ahead of his time in how he conceptualized medicine. He was a physician, and he's considered the quintessential American psychiatrist before we actually had psychiatry. But he was a physician, and he, like I said, was really ahead of his time. And this is a quote that he had, over 200 years ago regarding addiction. He says, "My observations authorize me to say that persons who have been addicted to them," and he's talking about spirits, he's talking about alcohol, "should abstain from them suddenly and entirely. Taste not, handle not, touch not should be inscribed upon every vessel that contains spirits in the house of a man who wishes to be cured of habits of intemperance. Habitual drunkenness should be regarded not as a bad habit, but as a disease." And so that was pretty profound. And if you think about it, he was coming to this conclusion way before we had any of the evidence that looked at the brain, that was able to look at the depletion of neurotransmitters and identify MRI scans and everything else. But this was something that he was able to observe over and over again in the patients that he was treating. He said, "Drunkenness resembles certain hereditary, family, and contagious diseases. Nearly all diseases have their predisposing causes, including intemperate use of distilled spirits." So when he was studying and seeing these patients who had alcohol problems, he was able to recognize patterns, and these patterns were similar to other contagious disease or even genetic diseases at the time. He identified alcohol as the causal agent. So for somebody who was intemperately using alcohol, somebody who was using alcohol to excess over and over again, then it would result in the primary symptom of loss of control. And he also determined at the time that truly abstinence from alcohol was really the only cure to help these people. As such, he really was leading was a forerunner in creating what were called sober houses at the time. And so the treatment that he would prescribe, or at least one of them, was to help the communities build some sober homes by which these folks who were suffering from this disease of alcoholism that they would become to call later, where they can be in a safe environment and not be exposed to alcohol anymore in order for them to get their lives back. So this disease model, then, it took a long time from Benjamin Rush, but up until 1956, the American Medical Association defined alcohol addiction as a disease because it is progressive, meaning that it continues to get worse and worse over time if it is left unmanaged or untreated. It's predictable. So if you can recognize somebody early on that they have an alcohol use disorder, it's pretty predictable about what their life will look like, what kind of symptoms they will have, what kind of problems they will have over time if that is not managed effectively. It's primary, meaning it's not secondary to something else, but actually it can be a standalone disease. It may occur with other diseases, but in and of itself, substance use disorders is a primary disease. It's chronic. It is not an acute disease. So sometimes people make the mistake of thinking of addiction the way they do of pneumonia, for instance. And so, for example, somebody who has a really bad case of pneumonia, they catch a bug, they have to go into the hospital, get fluids, and get some antibiotics or other medication to treat the bug. And after a few days or longer, then the bug is killed, patient's cured, and they can go on their way. Some people think wrongly that that's how you should consider and even treat addiction, but it doesn't work that way. Addiction is a chronic disease, and it takes a long time, if not a lifetime, to at least get under control and then continue to manage. And then sadly, as I am sure every viewer is aware of the horrible overdose risk and deaths that we see in the United States. And this Friday, I believe it's this Friday, is National Overdose Awareness. So those of us who are in the field are well acquainted with the reality, the sad reality, that addiction can be a terminal disease if left untreated. It took us psychiatrists a while to come to grips or wrap our own heads around this concept of looking at addiction as a disease. And it wasn't until 1972 then that the American Psychiatric Association accepts the disease model of alcohol addiction. So with the disease model, let's look at diabetes, for instance. So with diabetes, you have an organ that's become impaired. And in the diabetes instance, it's the pancreas. And then the defect that occurs because of that impaired organ is in the islet cells, so specific cells within the pancreas that are become dysfunctional in glucose metabolism and the ability to really move sugar in and out of the appropriate cells and organs. And then there are predictable symptoms that occur. People drink too much water, they eat too much food, and they pee too much. And so those are symptoms of the organ, the deficit, and the symptoms of diabetes, put very simply. So in addiction, where you have the primary organ that has become impaired is the brain. And the specific defect identified is impaired reward circuits, which has been the source of study in the brain for the last several decades. And then predictable symptoms that occur, just some of them would be loss of control, compulsive use despite knowing the harms, for instance, and then also cravings. And these are just some of the potential symptoms that somebody could have who suffers from addiction. The American Society of Addiction Medicine in 2019 came up with what I would consider a pretty good working definition of addiction based on my own experience working with patients for the last 20 years and also the available evidence. And what they say is addiction is a treatable, which is very important for people to understand and give them hope that this truly is a treatable disease. It's chronic, like we mentioned earlier, chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And one of the other important public health messages is that prevention efforts and treatment approaches for addiction are generally, as a whole, as successful as those for other chronic diseases. And that's really important that everyone comes to understand. Which leads us to the biopsychosocial model of health. And when you look at this model in the addiction framework, there's the biology. So the particular biology that we're focused on with addiction is the brain. And the brain is affected by a number of things we'll talk about a little later. Genetics, exposure, at what age will somebody be exposed to a particular drug? What kind of vulnerabilities do they have from their parents just by virtue of being born with certain genetics? Then there's psychological domain that is important to consider. And we know that in almost all of health, though during periods of stress, for instance, psychological stress, that puts physical stress on the body. And diabetes even, when during periods of heightened anxiety, during periods of depression, then it can create inflammation and it can create other problems that are downstream effects within the body that make diabetes worse or could actually put somebody at risk for developing an infection, for instance. And we also know that how we think about our health, our psychology about our health, and the decisions we make has very important impact on whether or not we get a chronic disease or like addiction and how we manage that. And then, of course, I think everybody would naturally, inherently recognize the importance of our social network in whether or not we develop addiction disorders. So if we grow up in a household that it's very common, for instance, to drink heavily, to use various drugs, we are more likely going to also find ourselves drinking heavily or using various drugs too. And same thing with our peers, etc. So if we look at the biology and focus on the biology for a moment, we know the brain, very, very simple here. This is an image from the National Institute of Drug Abuse. And if you break down the brain into three basic areas of importance, one is this very middle part of the brain that's called the basal ganglia. And the basal ganglia has one of my favorite organelles within it. It's called the nucleus accumbens. And it's the nucleus accumbens that releases dopamine. And dopamine is that chemical that is released whenever we're engaged in something pleasurable. So whether it's a good meal, whether it's exercise, whether it's sex, whatever it is, getting in from out of the cold and going before warm water, dopamine is released, and that's interpreted by us as very pleasurable and therefore very, very rewarding, and which is all well and good because that helps us do things that are supposed to be good for us. So those things that are rewarding are supposed to be good for us. We get that natural rewards. The problem with addiction is if we get exposed, especially at early stages in our life, to drugs of addiction that release artificially very large amounts of dopamine, then our brains start getting short-circuited, if you will, to put it crudely, that our brains actually start wanting more and more of that type of reward and less of the natural rewards. And that creates a lot of problems for us. So that's one area of the brain. Another area of the brain is the amygdala or extended amygdala. And that's an area of our brain that really makes us feel keyed up and even miserable. It's our fight and flight organelle. So our bodies are designed such that when we are faced with situations that are dangerous, we need to get geared up and ready to either flee the situation to save ourselves or put up our dukes and try to fight our way out of the situation for our own preservation. And it's the amygdala that is one of the areas that's really important for that. We also know that over time, well, number one, some people are born with amygdalas that are overactive. And so they're always keyed up. And if they get exposed to a substance that calms them down, that numbs them, it's going to be very enticing to continue to use that substance because they feel so miserable. But also, one of the things that we know about addiction is that if somebody is using these substances long enough, over a long enough period of time, not only does the dopamine receptors in the brain start decreasing and people don't experience the same kind of pleasure with natural rewards, but the double kicker is this amygdala part of our brain gets even more activated and you go through withdrawal and you feel sick, but then also you get this heightened state of fight and flight misery and crankiness and feeling stressed out. And that's sort of your baseline. And so there's this sense of having a dark cloud over your entire life existence because of the low dopamine, but then also this miserable existence because of the overactive amygdala. And then the other really important part of our brain is the prefrontal cortex. That's that frontal area of our brain that's important, that really sets us apart from other mammals in the animal kingdom. We have more neurons here compared to any other brain in the world. And this helps us to make good, rational decisions and able to look into the future and say, okay, if I take a course here, then it's going to lead in this direction. If I make a choice this way, it's going to lead in that direction. This one's going to be good for me, that one's not. What happens in addiction over time, those things are all connected and really cuts off that healthy communication between that prefrontal cortex and those middle parts of our brain, setting us up for some difficult times and how we manage it. So it really isn't come down, it also does not come down to nature or nurture, but really nature and nurture is the best way to think about it. So we know that our genetic load is going to influence the type of brains that we are born with, whether we asked for them or not. And some of us are born with brains that are very risk avoidant. And so we try to stay away from anything that could be potentially harmful. Some of us are born with brains that are always seeking the greatest thrill and the greatest push that we possibly can. And that can lead us to some addiction problems as well. Some of us are born with brains that are likely to have addiction. And we know from very sophisticated twin studies that patients who are, that kids, twins, for instance, who are separated at birth, if they are born to somebody, a parent who has a severe alcohol use disorder, and they go to a home where drinking is not allowed, or the other twin goes to a home where drinking is pretty common, both of those kids have strong likelihoods that they will develop addiction to alcohol. And so that's a lot of a genetic load that puts them at risk for that. But then it's not just genetics, right? And so we know also that the people that we are raised by and among and our peers are going to have a dramatic influence in whether or not we even start using drugs or alcohol in the first place. And then if we're going to be using those in a way that is risky. One of the fascinating areas that is gaining more and more research over even the last few years is this area called epigenetics. And this continues to blow me away. And this is the reality that environmental factors, life situations, and biological processes can turn on and turn off certain genes that we are born with. I mean, for the longest time, we used to think, well, those are the genes we're born with, and they produce their proteins, and they create what they need to create, and it's pretty static. But actually, that's not the case. And the environment that we are in has a huge impact on whether these genes are turned on or turned off. And they can actually, if they get turned on a certain way, then that actually could be passed on to future generations. So critical development periods of our brain include when during prenatal times, especially during puberty and especially during young adulthood, that these are brains that are very vulnerable to the environment and it can have long-lasting changes. One study that comes to mind right now immediately is a study that has been done with rats where they expose male rats to cannabis. And these male rats who are exposed to cannabis, their epigenetic environment changes the production of these genes such that they have children and grandchildren that have greater likelihood of drug-seeking behavior, that they have enlarged hearts and other things. And that was from the male rat exposure to cannabis. So very interesting stuff. And again, this is like much area of the brain right now. We're just scratching the surface about what are the potential implications of epigenetics and what we are exposed to. This is a dynamite quote that's in a line by Stephen King for one of his characters in the book called The Wasteland. Beating heroin is child's play compared to beating your childhood. And really a testament to the fact that our childhood environments have such a significant impact on who we are as human beings across our lifespan. And one of the ways that we notice this, or at least we've observed this and studied this, is through adverse childhood experiences. I suspect that most of you probably have heard of this by now, but if not, adverse childhood experiences, or ACEs, these terminology that originated in the mid-90s. A very, very large study that was done through the CDC and Kaiser Permanente in California, where they looked at over 17,000 patients and looked at various factors that contributed to health outcomes. And not only health outcomes, but also social outcomes like incarceration and employment, and identified physical abuse, emotional abuse, sexual abuse. So if you were a child and you experience physical, emotional, or sexual abuse, each one of those is gets 1 point for an ACE score. If you experience physical or emotional neglect in your home during your childhood and adolescence, then each of those would be another score. If you experienced a home where there was untreated mental illness, where there was substance use, where there was divorce, or a mother who was treated violently, or a family member who was incarcerated, each one of those additionally would be counted as a point. And you add those up, and there was a dose response effect that these researchers were able to determine that put people at high risk for various problems. And people with ACE scores of 6 or more die on average 20 years earlier than those who did not have any of these ACE factors. You could see that the level of lung disease and adult smoking 3 times more, if you have 4 or more ACEs, your level of lung disease and smoking as an adult increases by 3. Number of suicide attempts increases by 14. And likelihood of developing IV drug use goes up by a factor of 11, just as some examples. 67% of the population have at least one ACE score. And I like the pyramid graph here by the National Health Corps, where they start at the bottom with the adverse childhood experiences and then recognize that the further up you go, it disrupts neurodevelopment, it disrupts social, emotional, cognitive impairment, adopt high-risk behaviors, and then you see disease and then potentially early death as well, leading to President of the American Academy of Pediatrics at the time saying adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. So when you think of biological treatments, so we're going to take apart each of these spheres for the time being. So if we look at the biology, okay, what are biological treatments that are available? Well, the first thing you think about is medications, or at least what most people think about is medications. For addiction, we've got FDA-approved medications for opioid use disorder, alcohol use disorder, and tobacco disorder. And so those are the only three substance use disorders that we really have FDA-approved medications for. And then we can use some medications offline for other addictions, but that's sort of the play that we are faced with right now. We can also think about using medications for other psychiatric disorders. We know that there are a lot of that substance use disorder is often combined with other psychiatric disorders. And so there's medications that we can prescribe to help with those psychiatric disorders that make it more likely and to get somebody the help they need for their addiction as well. But beyond medications, one of the things that you think about is diet, also exercise, and also sleep. So these are three core biological features that we can encourage our clients or our patients who are seeking help to really focus on just as a basic level of care to make it more likely that they improve and get where they want to be in a state of health. And then also neuromodulation are newer techniques. And these are strategies that actually we here at the Rockefeller Neuroscience Institute are studying right now, and including deep brain stimulation, magnetic stimulation, and then also focused ultrasound. And the idea being is using some of these techniques to be able to impact and influence these tracks in the brain, the neurobiology, to help people with their cravings, to feel better, and to get on their way of health. So those are all different types of neuromodulation treatment. And then if you look at the psychological sphere, there are a number of different treatments, and we're going to go over the evidence-based treatments. But this slide here just is an attempt to show you the various contexts by which the talk therapy treatments can occur. So one way is through individual therapy, and that's where you have a clinician who is trained in, hopefully, in evidence-based therapies, and they're meeting one-on-one with the client or the patient. This is really ideal for people, especially who have co-occurring severe trauma that needs to be stabilized, because it's a lot more difficult to do that in group therapy. Group therapy is a context of therapy that has been historically associated with a lot of addiction care. It's something that we here, even at Western University, make use of a great deal. And I would guess and assume that much of addiction treatment in your local communities is made up in group therapy. Family therapy could be another context, and we'll talk about some of the family therapies that are being done. It can actually be done with the person who is suffering from addiction, or it can be done with the family in ways to help equip the family to help the person who is suffering. Couples therapy, of course. So here is the case where, again, it can be an actual couple who is working together to try to help either both who are in the throes of substance use disorder or one of them. And then another thing we do, especially in certain treatment contexts, such as intensive outpatient programs or even residential treatment programs, it's often very helpful to get many families together and in the same room and be able to process and consider and think through how to go forward with strategies to help. So what are some of the benefits of group therapy? One of the best benefits is just the peer support that one would receive. There's also a reduction in isolation. Addiction is a very isolating and lonely condition. And having others who are in the same boat, and and then you start realizing, wow, I'm not alone. And what I'm experiencing is not just unique to me, but it seems to be pretty consistent and common with everyone else in this room. And there's a degree of hope and comfort in that you don't think you're the only one. Another value of group therapy is that you get to see people get better. And so you are able to watch in real time the progress that others have and know that, boy, you can get there as well. Ability to gain feedback. One of the other values that I, as a physician, I, as a psychiatrist treating addiction, appreciate about group therapy is when I'm leading a group of people who have substance use disorder, their fellow peers, their fellow patients are able to really call them out or confront them in ways that I don't necessarily have the ability to do without having that lived experience. And that can be very powerful as well. So there are many other values and advantages to group therapy. There's also a lot of advantages to individual therapy. One of the, of course, most important advantages is that it's going to be an individual therapy. You're really tailoring as much as you possibly can to that specific individual. It's easier to create a trusting and therapeutic alliance with an individual as opposed to a group. It can be done in a group too, but it takes a little bit more time. More time can be spent with specific needs, whether it's other mental health needs or interpersonal issues that are really specific and private and things that a person may want to deal with, not necessarily in a group session. So here is the next two slides are going to be a list of evidence-based treatments for substance use disorders. And we'll superficially talk about these and then dive a little bit deeper in the following slides. Cognitive behavioral therapy, or CBT, is present focus, teaches skills that are available, assisting people in gaining initial abstinence from drugs or in reducing their drug use. Contingency management, behavioral strategy that takes advantage of our natural tendency to base our behavior on rewards and punishment. Community reinforcement approach combines behavioral strategies and environmental contingencies to support abstinence. Relapse prevention techniques we'll go into. 12-step facilitation therapy is a specific manualized therapy that helps clinicians help their clients or patients get involved in 12-step programs. Dialectical behavioral therapy is a therapy that was originally constructed to help patients with a severe personality disorder called borderline personality disorder, and be able to use much what is learned in that context that can also be applied to addiction. Motivational interviewing, I've got several slides on that because it's one of my favorites, so I'll dig into that more. And then yoga, mindfulness-based practice. There are more and more studies being done on this. More and more evidence that is coming out, and it's still sort of a young field regarding the evidence showing promise, but still worth trying to investigate. All right, so cognitive behavioral therapy is a therapy that has been around for a long time, founded by a couple of psychiatrists who were very dedicated and creative in the 1960s, Albert Ellis and Aaron Beck. And this is probably the therapy that has been researched the most. It's structured. It's easily studied against what you would call placebo, for instance. And so it just lends itself because it's very focused and structured to research. So it's available. I think most clinicians nowadays have some degree of exposure and proficiency in cognitive behavioral therapy. It's really focused on the present. It's not so much like when somebody might think of psychoanalysis and Sigmund Freud, which kind of goes into more of your past and the patterns that have created in the past. This is much more present focused, and you're looking at thoughts, how those thoughts, those automatic thoughts affect our behaviors and emotions. A lot of what the cognitive behavioral therapists will help patients identify is the negative automatic thoughts that we just have, and especially these negative thoughts about ourselves, negative thoughts about the world, and negative thoughts about our future, and to be able to address those. And when we do, then it can affect our behavior and emotions, and vice versa. ABCs of cognitive behavioral therapy. So there's an activating event in your life. This produces a belief or a series of thoughts, and therefore it produces consequences. I use an example, even this week, I was at a very public event here at our university, and it was a large hall, and I saw one of my colleagues that I hadn't seen in a long time across the hallway. And I waved, smiled, and gave him a big wave, and he looked at me and then looked away. And so that was the activating event for me. And then the immediate thought I had was, oh my gosh, is he mad at me? And what did I do? And then the consequence was, oh, I started feeling bad. I started feeling sad. I started feeling worried. So what I was able to do is go back to that belief and thought from that activating thought and try to think of other reasons why he may have looked away at the time. You know, maybe he didn't see me. Maybe somebody had just called him from the other side of the room that he had went to. And maybe he certainly didn't have any negative feelings towards me. And so that just gives you kind of a taste of how this works with cognitive behavioral therapy. So contingency management is getting a lot of attention right now, especially when it comes to stimulant use disorders like methamphetamine and cocaine. And contingency management really takes advantage of our learning and how our behavior can be shaped by rewards or punishments. So carrots or sticks, if you will. So you all probably know this, right? So a lot of people enter treatment, and we see this all the time because they have been given an ultimatum by a spouse, by a parent, by an employer. And it was either you go do this or I'm out of here or you're fired, I'm getting a divorce, whatever it is. And so there's sticks that often are used to actually get people into treatment and even keep them into treatment. Many of our patients, for instance, that we see are in treatment and doing well because they're fighting to get their kids back after they've been taken away from court and need to demonstrate that they are healthy enough to be able to care for their children. Another example of this comes to mind is back in the early 70s during Vietnam. Sadly, many of our service men, and primarily servicemen at the time, became users of heroin. And you can imagine how easy it would have been in such a traumatic environment for all that they were experiencing, seeing, smelling, hearing, doing at the time, and how traumatic that was to have a ready opioid available to them to be able to numb them and help them escape from those very difficult feelings and circumstances that they were experiencing. So sadly, a number of our servicemen then were using heroin and unable to really come home. And so what Richard Nixon did at the time was instituted a plan called Operation Golden Flow. And so our GIs had to give a negative urine test in order to be able to send home. So it was a carrot to stop using heroin in order to be able to go back home and get out of Vietnam. So that's just one example. So classical conditioning. This is a type of learning where this is Pavlov and his dog. I think this is a great picture. But as you're probably aware, is that Pavlov studied dogs, and he specifically was able to pair a neutral stimulus, the bell ringing, whenever the dog was exposed to a plate of food. And we know when dogs are exposed to food that they start salivating. And so what he did was he rang a bell, exposing the dog to that when they got a food plate. And so the brain was wired such in that dog that over time, all he had to do was ring the bell and that dog would salivate. Okay. And so that's what's called classical conditioning. And we see this at play in a lot of our patients who have addiction because they've been conditioned over time to associate certain people, certain places, certain things with the dopamine release of their drugs or alcohol. And so that's why, a lot of treatment historically would advise patients, clients, peers to pay attention to people, places, and things. And those areas that could make it more likelihood that all the bells and whistles go off in your head because you're getting triggered from those things. I even have patients that will inject water because they are so triggered by that injection. Even if they don't have a drug, they get this experience that's dopamine release just from having a needle enter their arm. And that is another example of this classical conditioning. Operant conditioning. And so operant conditioning is a different type of learning. And this is where a person or an animal will repeat an action if there's a positive reward or avoid an action if there's a punishment. Again, this is using the carrot and stick. Once the behavior is learned, then the person will continue the behaviors without the reward or not to return to the behaviors that caused the punishment. So we do this all the time with dog training. This is how much of what we do for dog training. Here's a picture of myself with my Airedale Terrier, Chester. And my son was able to teach Chester to stick him up, hold his paws up on command. And here you see me holding up a treat. But Chester is able to do this when we say these words. This took time, and he was able to do this because of the rewards that was offered with the doggy treat. So you can use this in contingency management, and this is what's being really utilized and has a strong evidence base behind it, like I mentioned earlier, especially for stimulant use disorders, methamphetamine, cocaine. So it's the systematic delivery of positive reinforcement for desired behaviors. And you're able to use in the treatment. So you're able to use vouchers or prizes that can be earned, for example, in you giving methamphetamine-free urine samples. So the idea being you've got patients and your clinic is set up such that people know for every urine drug screen, they could either get a voucher or a gift certificate, or you could get creative and do things like for every negative urine drug test, you can get a voucher to be placed in a bingo thing where you're able to pull that out at the end of the year, or a roulette wheel or something of that nature, where you're able to get another prize. So these are the things that you can be creative with. It really takes advantage of the habit loop where you've got you got a cue, you change your routine, you get the reward, and that's how you deal with the cue over time. And so it frequently monitors the target behavior, provides incentives when the target behavior occurs, and then you remove the incentive when the target behavior does not occur, and then you repeat. And so this has been helpful in the sense that you've got patients who have really strong, severe cravings for methamphetamine have been really hard to overcome. There's actually value then in giving them that space and the time when they are faced with a trigger or a craving and they have a choice of whether or not they're going to use, then actually the thought of having that reward can actually make a difference, and then come into treatment and say, yep, I'm able to give a urine that does not have methamphetamine in it, and I know that will give a reward. The way you actually make that even stronger, the potential for that reward stronger, is that you build over time the power of that reward. So for instance, if you give us one negative urine drug test, it's worth, let's say, $1. But if you give 3 in a row, then it's worth $10. If you give 5 in a row, it's worth 20. If you give a positive one during that time, it goes back to 0. So that's a way to continue to reinforce the rewards and make some behavioral change occur. Community reinforcement approach involves behavioral skills training. It's a holistic approach, social and recreational counseling, marital therapy, motivational enhancement, which is another manual that uses motivational interviewing, but also important regarding job counseling and other relapse prevention techniques. CRAFT, community reinforcement and family training. This is a type of therapy that teaches these strategies for loved ones who are trying to help somebody with a substance use disorder. So this isn't specifically targeted towards the patient to develop these skills, but it's really the people in their life who is going to develop these skills and help people understand what are the triggers that your loved one has for using. What are positive communication strategies that you can practice and be engaged in that make it more likely that it's going to be helpful for your loved one? What type of own self-care do you need to engage in to be all that you can be to be of support to your loved one? What are the problem solving? What are the family? What are the goal setting? These sort of things. So it's family members and loved ones are learning basic practical strategies to help the identified patient change their behavior. Relapse prevention therapy is also manualized out there. It incorporates cognitive behavioral therapy strategies, emphasizing having awareness and warning signs of the triggers that occur. Again, as mentioned earlier, with the classic conditioning of people, places, and things, being able to recognize that, being able to slow down, and in advance while you don't have those cravings, coming up with strategies and plans and escape routes for how are you going to manage yourself and make decisions that are really good and healthy for you when you are faced with these various triggers. And then you practice those. All right, motivational interviewing, which is hands down one of my favorite techniques. And there's the book, the main text for that is Motivational Interviewing, Helping People Change and Grow by Bill Miller and Stephen Rolnick. And there's in the 4th edition, I believe is the latest edition now. What they state in the book, a large proportion of healthcare is concerned with managing chronic conditions for which people's own behavior and lifestyle determine their future health, quality of life, and longevity. Thus, physicians, dentists, nurses, dietitians, and health educators are regularly engaged in conversations about behavior and lifestyle change. And these conversations can make a dramatic impact on how somebody actually behaves. There is power in these conversations. So you find yourself dealing with patients or clients. They've got themselves up in a tree because of their addiction, and they need to figure out how do they get down and stay down. Well, there's a number of different strategies you can approach this by. One is you can blame the patient, and you could say, you know what, patient, you created your own problem, and you were the one that wanted to get up in that tree. You figure out how you got to get down and let me know when you get down. All right, so that's one strategy. You can also, as a healthcare provider, get a ladder and go up to that tree and pick up one of those patients and bring them on down and say, okay, I saved this patient, I rescued this patient, which sometimes people need a ladder. But what's going to happen when you leave, that patient, that goat, will climb up that tree because that's where he likes to be. She likes to be. You can kind of coax and cajole to get them down. You can threaten them to get them down. Likely, again, when you are not there, they're going to go back up in that tree, especially if they've had a lifetime of addiction and all of the things that keep people doing, all of those things they know is not good for them, but it's the insanity of the addiction. However, what you can do and what motivational interviewing can do and help you with is You find a way that keeps them down for the long term with or without you. And you do that by creating an environment where the person is able to consider the risks and benefits of their behavior based on their own goals, values, etc. And so what you're trying to do is help draw out their internal motivation for change. So motivational interviewing is about arranging conversations so that people talk themselves into change based on their own values and interests. Attitudes are not only reflected in, but are actively shaped by our speech. And so what this particular set of techniques, and really it's an art of being with somebody, is paying attention to the talk that they are giving you and be able to help mold and shape and accent and emphasize certain things and focus on those. It's attending an actual language about how we change and how to have more effective conversations. It's a collaborative conversation for strengthening a person's own motivation and commitment to change. And that is the key. It's not what we as the provider are bringing to that relationship and based on what we believe they need in order to change, but the key is trying to determine what it is that they need in order to change their own values. It's also, this is the trans-theoretical model of change, or what's also been known as the stages of change, which parallels very nicely with motivational interviewing. And it recognizes the reality that most people who are stuck in addiction, it's not an all or nothing thing when it comes to motivation. And a lot of people assume, well, either you're motivated or you're not motivated. And if you're not motivated, then there's no sense helping you. Well, that's not really true. That we as human beings have a spectrum of motivation, and it occurs on a continuum with any behavior that we would want to do. And these researchers were able to break it down into various stages that I think are helpful. And so, for instance, you could look on your own and study this later, but pre-contemplation is that stage where the person has no intention of changing the behavior at all, whereas action stage is on the opposite end of that, where they have decided, listen, I really need to make a change. My drug use has created a lot of harm in my life to myself and others. I know where this is going to head if I don't make a change, and I am making some changes now. If you approach your client or your patient who is in this pre-contemplation stage as if they were in action stage, it's going to cause a lot of frustration for both you and the patient. And it may create such an environment where they don't want to come back because it's so uncomfortable or painful with what you are trying to do. So a lot of attention should be placed in trying to understand where this particular patient is along this continuum, and then be able to model your type of approach accordingly. It recognizes that we as human beings are ambivalent. That meaning that we have reasons why we want to make a change when it comes to certain behavior, and we have reasons why we want to be able to keep doing what we're doing. And motivational interviewing will help the person recognize there may be really good reasons somebody has for continuing their drug use. And you acknowledge that those could be very valuable or at least viable reasons or understandable reasons why they would continue to use. But they get stuck. And the easiest path to continue the behavior is just that, is to continue the behavior as opposed to making a change. So what motivational interviewing is attempting to do is help get them unstuck and start heading towards that pole of health. A number of principles that you can look up later, just looking at time. So it's interview, it's the ability where you're creating an environment as the provider where the actual person is able to safely consider, to view, to see their own motivation, the own choices they have, and what it is that they ultimately want to do regarding their behavior. It's more of a collaboration with the person as opposed to confrontation. It's not done to or on a person, but it's done for and with a person. You're trying to, really more of the emphasis is on eliciting, drawing out again, what is inside as opposed to providing a lot of education. There's a role for education. There could be even a role for confrontation. But when you're thinking about pure motivational interviewing, these are the concepts. Recognizing autonomy, that the person is ultimately responsible for the own decisions they make, and they're the ones that have to live with those decisions, as opposed from coming at it as more of a paternalistic or authoritarian perspective. And cannot overemphasize enough the importance of compassion for this or any of the other therapies. Mindfulness-based therapies, there's mindfulness-based relapse prevention, mindfulness-oriented recovery enhancement, acceptance and commitment therapy, and DBT also. It seems to have better evidence for those who have co-occurring mood disorders, and that's what we're seems like is bubbling to the top as far as efficacy. The matrix model is another model that has become more important and gotten more attention with our methamphetamine epidemic that we're seeing in many parts of the states right now, especially again, since we don't have any medications that are FDA approved for that. But this is a model that is shown to have some efficacy in managing and treating methamphetamine. So it's manualized 16 weeks. Really addresses the psycho and the social aspects of addiction, integrates several interventions such as individual counseling, CBT, MI, positive reinforcement. Many of these features that we discussed in the previous psychotherapies, makes use of random urine drug testing, also education, and 12-step facilitation. Briefly, dialectic behavioral therapy in addiction has been fashioned beyond just personality disorders, but also can be helpful. Many of these concepts integrating into a therapy and a treatment for people who have substance use disorders. Four main components, looking at mindfulness. How do you tolerate stress and distress? How do you manage your emotions during highly dysregulated patterns of behavior that you're used to in situations where you have not historically been able to manage those in a way that have been healthy? So how do you learn how to do that? There's techniques how to do that. There's also techniques in practicing how do you interact with the people in your life, especially during times that are even positive interactions or times that are stressful. And how do you do that in a way that's going to be healthy for you and constructive, and not do it in a way that's going to create more problems for you? And so that's what this is focused on. 12-step facilitation is another evidence-based treatment. It's manualized. So there's actually a book that a therapist, clinician can go through using 12-step group-based model of treatment. Emphasizing and really focusing on attending 12-step meetings, the concepts of acceptance, of recognizing in the first step of the 12 steps, recognizing you are powerless over your addiction and that you need something greater than yourself to be able to get better. And you surrender to that reality, and then you receive the help from others, and you get active. So one of the key elements is participation, participation, participation. It's important to note that when you look at the vast majority of where people are receiving help for their substance use disorders, for their addiction, consistently people are getting help across the country and really across the world through self-help groups. And that is where I would put this within that social domain of the biopsychosocial. So it's important for us to understand, those who want to help people understand what are the 12-step groups and how can they be helpful. So here's a picture of Bill W. and Dr. Bob. Bill W. and Dr. Bob were the two gentlemen that really put the concepts of the 12 steps together into what is currently known as Alcohol Anonymous. Back in the 30s, they were people who suffered from alcohol use disorder and tried their best to get better over the years on their own and different types of things, and just were not successful. And what they finally hit upon is, as they helped one another and got part of a group that was helping others in their service, they found that they were actually able to maintain their sobriety. And so there was something special and important about serving others that helped their own treatment. And they determined then that there were a number of concepts that they can follow. And this has just blossomed ever since. So there's over 2 million members across the world, basis for numerous other recovery organizations. 1951 won the Lasker Award, American Public Health Association, for the value from a public health standpoint. Henry Kissinger described Alcoholics Anonymous as America's gift to the world. And you can literally go to any country right now and find an Alcoholics Anonymous meeting. The Big Book, which is the main textbook of AA, which was created in 1939, is among 88 books that have shaped America. U.S. Library of Congress. It's really important to understand that over 25 years of National Institute of Health facilitated research has concluded that AA and 12-step facilitation is cost-effective and can be a very, very helpful intervention. Keith Humphreys is a psychologist researcher and has done clinical work outside of Stanford, who studied this a lot, and encourage you to look at his work if you have an interest. And over time, has good or better results than quote unquote modern interventions. Project Match, which was done several decades ago and combined a number of different therapy modules, including the 12-step facilitation, cognitive behavioral therapy, motivational enhancement therapy. Over time, since those studies have occurred, 12-step facilitation has had 60 to 70% more subjects in full sustained remission at 1 year, and abstinence, more than half abstinence at 3 years. There's definitely a causal impact of AA on outcomes for drinking. And the extraordinary thing about this is a very inexpensive way to be able to manage alcohol use disorder. And almost every community has access to Alcoholics Anonymous meeting, and it doesn't cost the public one dime for people to be able to participate in that. How does it work? Well, there's been some studies that have really dug into this to try to figure out what are the elements that work. And there are several. One is it changes the social networks in support of abstinence and recovery. So it really changes your peer group, one from a peer group that could be using or encouraging you to use, to one that is identified themselves as, hey, we cannot use alcohol. And so that is part of your peer group. It boosts abstinence, self-efficacy, and recovery coping skills, because you are able to see your peers in these groups get better and get better over time and really become attracted to the type of life they have now. You're able to help maintain that recovery over time through that strength of others, and increases spirituality, which has known positive outcomes for many health disorders. Decreases depressive symptoms, decreases cravings, and decreases impulsivity. So these are several factors that have been identified of how Alcoholics Anonymous can help. This is a wonderful quote from Carl Jung, who had a letter correspondence with Bill W. back in the late 30s, and maybe early 40s. And research suggests that AA's effects are most likely what Carl Jung determined are called the protective wall of human community. And this, I think, is a wonderful encapsulation of what I consider to be the value of 12-step programs, and much of the treatment that we do, even in group settings, is the protective wall of human community, recognizing that we are much stronger when we have connections, positive connections with others. There are so many different types of 12-step or mutual support groups that are out there now, and I encourage my patients to try to go to as many different ones as you can to figure out what's the best fit for you. And so not only, of course, is AA, Narcotics Anonymous, there's programs called Smart Recovery or Rational Recovery that are much more based on CBT principles, and less so on spiritual-based principles. Celebrate Recovery is an example of a specifically Christian-based program. Recovery Dharma is a program that's based on Buddhist principles and is more trauma informed and focuses on empowering one who is suffering. But there are many, many others out there, and I try to get all of my folks that I'm treating into something like this. This is a very famous picture in the AA community in their history. But what I like about this picture is it really gets at the fact that AA members go to where the patient is or the person is who is suffering. And I think if we in modern healthcare can get to the point where we are actually able to meet the patient where they're at in every circumstance at their moment of need, then we will actually make the biggest impact in helping people long-term and the largest amounts of people. But anyway, I as a doctor can't go into be there with somebody 24 hours a day, 7 days a week, but somebody from AA can, or somebody from one of the other mutual support groups can. Peer support groups and peer recovery specialists have been also a wonderful asset to our addiction treatment programs over the last several years. And these are people who typically have lived experiences of substance use disorders, and they are part of our healthcare team to be able to go to where patients are and help them, knowing that they have these lived experiences and are able to have some credibility and insights in ways that maybe I, as the physician, do not have. And then, of course, now today, especially since COVID, you can get a 12-step or a mutual support group virtually anywhere in the world. 24 hours a day, 7 days a week. A lot of my patients today are using this. I have one patient that I even see this week, every week, and he logs into regularly a 12-step group virtually out of New Zealand. And so he's always sharing with me what his Kiwi peers are sharing in their meetings. And then what's really interesting is just the commonality across various cultures across the world of the experience of addiction and what it takes to get better. So these are available all over the place right now at the tip of your fingertips. Spirituality is another feature that I think is incredibly important when it comes to considering how do we help people with substance use disorders. So you think of biopsychosocial, but you could also think of biopsychospiritual, or spirituality as encompassing the whole model. This is a really important book that I've been able to read a couple of years ago, called Hostility to Hospitality, Spirituality and Professional Socialization Within Medicine, by a group, by a husband and wife couple out of Harvard. Actually, Michael Balboni, he is a chaplain there at one of the Harvard hospitals, and then Dr. Balboni is a family medicine physician there as well. And they, in this book, and I think it's so helpful, is recognize that, listen, the origins of our hospitals and healing professions, especially in the West, have been based on spirituality and driven by organized religious traditions. And that in many ways, with modern medicine and the modern industrial complex, is we've gone more and more away from the importance of recognizing who we are as human beings, beyond just the here and now and beyond the imminent. And this has led to very financially driven profit motives that drive a lot of healthcare, that really separates the patient from health and also from their clinicians, and has created a dehumanizing experience. And that really their argument, if I understand it correctly, is returning to a sense of spirituality and the ability to be able to talk openly about spiritual matters, which many patients want to do, and even many health professionals want to do, and make that more a part of the conversation, the better off all of us will be. And then they define spirituality as life centered in the person or objects of one's chief love. beyond oneself, however individually one understands that, and then religion as the individual and social structures that flow and facilitate chief love, including the beliefs, practices, relationships, and organization. And then the importance of faith communities. So much research has occurred, especially over the last couple of decades, that continue to support being active participants in and regular participants in faith communities and practicing various practices of that faith community has positive health benefits. And this is something that we try to address with each of our patients as well as much as possible, is try to help understand where are they coming at from a faith perspective, and are there communities that they can rediscover or discover anew, and try to get them the protective values of that as well. Also, social determinants of health are areas that have become recognized as essential and focused over the last several years, and public health efforts have been marshaled to try to address many of these in our communities. And so you think of things like work. I always say work is great medicine, because you get to have structure to your day. You wake up, you have purpose, you have order, and you have a sense of accomplishment and service at the end of the day. And so really try to get people the employment to help them and help their communities. You know, transportation is one of an area that can be very, very crucial to getting people treatment. Prior to COVID, just to give you an example, here in West Virginia, we've got people who live miles away, but really didn't have much access at all to get to us, because they just didn't have cars. We do not have a great transportation system like some inner cities do. And so they were not able to get treatment. But after COVID, one of the silver linings of the pandemic is we were able to really make use of virtual care. And so people can be treated in their home, which is huge when it comes to getting access. But again, simple things like making sure there are pharmacies. So I could write all the prescriptions in the world for medications for opioid use disorder, but if the patient cannot get to a pharmacy, or get to a pharmacy where they have the medicine or are willing to actually give the medicine that I've prescribed for various reasons, then my prescription is going to do them no good. And so thoughts about how we can ensure that people have access to pharmacies and have access to medications when they need them at all times to be able to help them. Dental care is another important aspect of our health. And we know this is that our dental health can have tremendous influence on the rest of our health. We have one of our resident physicians whose partner is a dentist, and they on their own developed a mobile dental clinic where they come to our residential treatment center. I believe it's once a week now, and they are able to care for our patients there who are at a 28-day residential program and making sure they're getting the dental care. So just again, another example. Childcare, big. So a lot of people can't access treatment because they are trying to care for their kids. Housing, and ensuring that people have safe and affordable housing and shelter to be able to help them thrive. These are basic needs that people need to have in order to be able to truly address all of their higher level of needs: food security, education. So SAMHSA has 4 major dimensions of recovery that they have identified should be areas of focus for public health policymakers and clinicians, et cetera. And so that includes health, expanding access to primary health care, just the basic needs, and where people are able to receive not only primary physical health, but also primary behavioral health, psychiatry, and other psychiatric and psychological services. Purpose, trying to help people establish purpose in their life through various opportunities, educational occupation, housing, safe, affordable housing in their communities, and then also healthy, sustainable communities where people can flourish. therapeutic lifestyle choices. So this is some work that has been done by psychologist Robert Walsh, where back in early 2000s, I believe it was, or 2011, recognized that there are a number of lifestyle choices that we can make that can be as effective or as helpful as psychotherapy or pharmacotherapy, really, in certain areas and certain times. And so these are simple things, again, and I broke these up into the biopsychosocial. So in the biological, exercise, nutrition, diet, relaxation, psychological, stress management, social, community involvement, being able to volunteer, healthy relationships, and then spiritual things like time spent in nature and considering greater purpose, considering the transcendence of nature, and then faith communities as well. So to sum up, again, health equals whole. The best treatment that one can consider is treatment that tries to address all of these domains, and this is really what we should aspire to as clinicians, as healthcare providers, and other programs that are really interested in trying to treat the whole person. So that is the biopsychosocial, and many of the elements that I've come to really appreciate are necessary to getting people better.